Okay, awesome. Hello, everyone. My name is Dr. Kainaat Javed. I am a vascular research fellow with the Department of Neurosurgery at Montefiore Medical Center, which is located in the Bronx, New York. And today my presentation is going to be about the Bronx endovascular thrombectomy score. So this was a clinical research project that I completed, and it's basically a prognostic score that we developed to predict functional outcomes in ischemic stroke patients who were treated with thrombectomy. So just some background information. Acute ischemic stroke occurs when there is a clot obstruction in one of the blood vessels of the brain, leading to an ischemic injury. An LVO, or large vessel occlusion specifically, refers to the obstruction being in one of the main blood vessels of the brain, such as the internal carotid artery or the middle cerebral artery. These are the arteries that make up the circle of Willis. And so historically, the way acute ischemic stroke has been treated has been with the administration of fibrinolytic therapy. So patients would get, IV TPA, tissue plasminogen activator. However, in the United States in 2015, the 5 landmark stroke trials were published, and they were ESCAPE, EXTEND, REVASCAT, SWIFT Prime, and Mr. Clean. And basically what these trials showed was that patients who were treated with thrombectomy, in addition to the medical management, had superior functional outcomes. And since then, thrombectomy has really revolutionized ischemic stroke treatment. It is now the gold standard with which we treat ischemic stroke patients. However, as people who work with stroke patients and provide care to them at our comprehensive stroke center here in New York, in the real world, clinical practice is that even after thrombectomy, successful thrombectomy, the truth is that patient outcomes remain variable. Some patients can have a successful outcome, a successful thrombectomy, and they still do not experience a restoration of neurological function back to baseline. And so for this reason, our research team was very interested in being able to accurately prognosticate patient outcomes after thrombectomy. And there are many purposes for doing this. So if we're able to predict how each patient is going to recover, that allows us to guide their individual recovery process, because then we can identify those who may need a little bit more of the rehabilitative services. And it also allows us to give an accurate picture to patients and their families so that we can manage their expectations towards recovery. So at this point, it is important to mention that there are existing prognostic scores that have been reported in the literature for ischemic stroke. Some of you may be familiar with the Hyatt score or the Thrive score or the PRE score. Now, these are scoring systems that have been developed either 10 or 15 years ago, and they basically consist of patient-specific factors, such as demographic information, medical comorbidities, clinical presentation, such as the patient's neurological exam. Perhaps they include imaging information, such as the extent of the infarct on CT head. However, the purpose or the way these scores have been used has been mainly to guide patient selection for thrombectomy. So, if a patient has a good Hyatt or Thrive score, that means the patient's likely to recover well, and then that would be a patient who would be a candidate for a thrombectomy. That's how these scores have been used. However, the question that our research group posed was slightly different. We were really interested in knowing, well, so if we have these stroke patients and they've already been selected for thrombectomy and they've undergone successful thrombectomy, how many of these are going to go on to recover well and how many will not? So that was the question that we were hoping to address. And for this reason, we thought there should be a prognostic score that not only takes into account pre-procedural metrics, all the things that I mentioned earlier, patient-specific factors, but also intra and post-procedural metrics. So things like, well, how long was the thrombectomy? What type of anesthesia was used? How much of recanalization were we able to achieve? And how did the patient do afterwards? Was there any recovery of neurological function? So we wanted to include all of those variables as well into our scoring system so that we can come up with the most accurate prediction for 90-day outcomes. So our study was a retrospective cohort study. All the adult patients who presented with acute ischemic stroke and were treated with mechanical thrombectomy over a 4-year period from 2016 to 2020 at our institution were enrolled in the study. So exclusion criteria, anyone who had more of a distal occlusion, not a large vessel occlusion, or had multiple thrombectomies over a short time frame, or we lacked follow-up data for those patients, or had severe baseline disability were excluded. And our primary outcome was 90-day functional status as measured by the modified Rankin scale. So some of you may be familiar with this. Modified Rankin scale just speaks to the degree of disability that a patient has. So if a patient has a score of 0, the patient has no neurological deficits, and a score of 5 indicates severe disability, while a score of 6 indicates that the patient passed away, unfortunately, from the neurological insult. But this was the scale that we were using as our primary outcome. And what we were specifically interested in were those patients who had a 90-day modified Rankin scale of greater than 2, indicating that they had moderate to severe disability. So that was the group that we were interested in evaluating. And then the variables that we included, as I mentioned, we had a very comprehensive list of variables. So demographic information, comorbidities, patient's clinical presentation, as well as the specific procedural variables and hospital course. For statistical analysis, we had a pretty thorough and advanced statistical approach. So there are 3 main statistical approaches that you can take to model building. All of this work was done, by the way, in conjunction with our biostatistician. But yes, basically the approach that was outlined was that there were 3 main ways to build a model. So the first approach is the p-value approach. This is the one that people are most often familiar with. So this is your traditional logistic regression model. You perform the bivariate analyses, and then you do the logistic regression modeling. That's one approach to model building. Another approach is the stepwise approach. So you basically take a logistic regression model, and then you add or remove variables one by one in order to optimize the R coefficient as well as the area under the curve, and to get a better fitted model. And the last approach is the lasso approach, which is also a spin-off of the logistic regression model, but it employs shrinkage, and it gives you a more parsimonious model. But anyhow, we use these 3 approaches in order to build or develop a prognostic score. So then we had 3 possible, 3 possible prognostic scores for thrombectomy, for post-thrombectomy stroke patients. My apologies, I should say. And then those 3 models were compared to each other using cross-validation. And the model for a prognostic score that had the highest area under the ROC curve was ultimately chosen as our final bet score. So a total of 224 patients were included in our analysis. Average age of our patient was like 65 years. About 70% of the patients in our population were female. As you can see, we had a large percentage of racial and ethnic minorities. So 30% were Hispanic, 30% were Black, 20% were Caucasian. And as you can see, there was also a high incidence of medical comorbidities in our patient population. Up to 70% of people had hypertension. And 134 patients, so about 60% of our patient population, had a modified Rankin scale of greater than 2, indicating functional disability at 90 days, which was our outcome of interest. So I present to you the final bet score. This was the bet score that was developed using the stepwise approach, so the second statistical approach that I mentioned earlier. And so this BET score has an area under the curve of around 0.82, which is pretty good, has a sensitivity of 80%, specificity of about 75%. And as you can see, up to 7 points can be awarded with the BET score. And the higher the score is, the greater the likelihood of 90-day functional dependency or functional disability. So if a patient has a score of 0, then the chances that the patient will be functionally disabled at 90 days is like less than 21%. But if the patient has a score of 6 or 7, the likelihood that the patient will be disabled at the 90-day mark post-thrombectomy is as high as greater than 99%. So that's very high. The variables that make up the BET score, they include smoking status. So a point is awarded if the patient is a current smoker. They also include history of diabetes. So 1 point for someone who has type 2 diabetes, type of anesthesia used. So 1 point is awarded if the patient had to be intubated. The time from arterial access to recanalization, greater than 45 minutes, would lead to an additional point being added to the score. And then the TICI score, this is the thrombolysis and cerebral infarction score. So this indicates how much of recanalization was achieved. A score of 3 means that the occlusion was completely opened up. So if a patient, did not achieve complete recanalization during their thrombectomy, they get another point. And lastly, a post-thrombectomy National Institute of Health stroke scale of greater than 10, which means that the patient had persistent neurological deficits even after thrombectomy, leads to the inclusion of 2 points to the BET score. So basically, the way the score would be used in clinical practice would be for each patient after they've undergone thrombectomy, the clinician or physician would just calculate the BET score and then look at and then using the score-based risk prediction chart on the right would calculate the risk for 90-day functional dependency. So some of our conclusions, basically the 2 patient characteristics that made their way into the BET score were smoking status and history of diabetes. This is pretty consistent with what's been reported in the literature, right? So smoking and diagnosis of diabetes, they are pretty significant vascular risk factors. And the theory is that they lead to suboptimal neurological recovery in stroke patients. The procedural metrics that were relevant and were included in the BET score were type of anesthesia, time to recanalization, and TICI score, which once again has to do with how much of the clot was removed and how much the vessel was opened up. So basically, if a patient required intubation or had a long procedure length, that likely hints at a more complex case, which is why having those additional points added on leads to worse outcomes. And also, if a patient has a low TICI score, meaning like the vessel was not completely opened up and maximum reperfusion was not achieved, then that also signifies that the patient is more likely to have worse outcomes. The post-procedural measure that made its way into the BET score was the post-thrombectomy National Institute of Health stroke scale. So if a patient continues to have persistent neurological deficits, even after thrombectomy, it just goes to show that there was no restoration of neurological function, there was no recovery. And so, or no immediate recovery, rather, I should say. And so that's why that is actually the strongest predictor out of all the other ones in regards to how the patient's going to fare in 90 days after thrombectomy. So some of the strengths of our prognostic score, the BET score, is that we included a pretty comprehensive list of variables. So, as mentioned, we included pre, intra, and post-procedural variables. Our patient population in the Bronx here in New York is extremely diverse. They also have a high degree of medical comorbidities, which is something that's not often seen with other study populations, but is a strength in ours. And lastly, we employed advanced statistical techniques in order to come up with this prognostic score. Our limitations is that, despite having over 200 patients in our study, it's still considered a relatively modest sample size. Unfortunately, our score cannot be used to prognosticate functional outcomes in patients with severe baseline disability. This was a decision that we made intentionally, actually, when developing the score, because pre-existing moderate to severe disability is such a strong risk factor for poor outcomes at 90 days. There's so much collinearity there that it had to be excluded. And our model, or our score rather, has been used at our institution, but is still currently pending external validation. And lastly, we talk about prognosticating outcomes, but at the end of the day, we're only looking at 90-day outcomes or 3-month outcomes after thrombectomy, which is still considered short-term. And so, additional work needs to be done to look at, how these patients fare 6 months or 1 year down the road, or how they do in the long term. But, for ease of use and ease of application, so that this can be implemented into all of your clinical practices, the BET score is available in the form of an online calculator at the following website. And lastly, if anyone's interested in this topic, we did publish a paper that in the Journal of Stroke and Cerebrovascular Diseases a few months ago. So in it, there's more information about exactly how we developed the score. It should be PubMed indexed. If you search my name, you'll find it, but please feel free to check it out. And at this point, I can take any questions or comments, but thank you everyone for listening. And I'm very grateful to my mentors who sponsored this work and brought me this far.
Thank you so much for your presentation. Now floor is open for the questions. If anyone having the questions, you can raise your hand or you can directly ask.
Sorry, I'll stop sharing my screen.
Yeah.